Our next presentation will be by Dr. Andrew Wang, Professor of Medicine and Chief of Interventional Endoscopy at the University of Virginia. Dr. Wang's clinical interests include ERCP, interventional EUS, and endoscopic resection techniques. Dr. Wang will be talking to us about the contemporary approach to the treatment of complex biliary stones. Thank you so much for joining us, Dr. Wang.
Thank you, Dr. Deloy, and I wanted to give a shout out to Dr. Shaw and Dr. Wani and all my friends at the University of Colorado at Denver. A lot of admiration for you guys, and thank you for allowing me to speak today. These are my financial disclosures and financial relationships. Learning objectives is in the slide deck. So I'm going to be talking about biliary stones, which is a very common problem for those of us who do ERCP. This is a standard ERCP. Patient has small biliary stones, let's say 10 millimeters or smaller in size. This is a conventional traction sphincterotomy. We're using blended current. And here we're trying to make it adequate for the size of the stone. So we're approaching the lateral duodenal fold. I usually cut and then reorient and make sure we're going in the direction you want to go. See normal exposed ampullary and biliary epithelium. And then we switch to a retrieval balloon and very easily are able to remove several stones, including here, I think this is the largest one. So very easy. I think it's within the armamentarium of anyone who does conventional ERCP. So the other technique that has been around for a while is that of endopapillary balloon dilation. This is a bit more popular in Asia and Japan, Taiwan, South Korea, but this can be done without sphincterotomy. This was a meta-analysis of randomized controlled trials back in the Red Journal in 2004, and actually found that the efficacy was about the same for papillary balloon dilation without sphincterotomy versus sphincterotomy and stone removal. However, the rates of post-ERCP pancreatitis occurred more frequently in the papillary balloon dilation arm compared to the sphincterotomy arm. And as such, in the United States, clinical standard of care is usually to not do this without a sphincterotomy. This is an example of an impacted stone at the ampulla. And this was one of my fellows from a few years ago, early on in his therapeutic training. And these cases are great. You can use a needle knife, get practice with it in a very safe manner. And you can see just with a few cuts, very easily, this stone is able to be ejected from the bile duct, as you can see here. Again, this is a very safe technique to use the needle knife, and we really wish they could all be that easy. So the ACG and the ASGE put forth quality indicators for ERCP, and I will focus on number 8, the frequency with which common bile duct stones less than 1 centimeter in patients with normal bile duct anatomy should be extracted successfully in about 90% of cases. Now, this is really expert opinion, and the real question is, in clinical practice, do these estimates hold up? This was a study that was led by Greg Cote and Jim Scheinman that we participated in. And using structured data fields in our EndoWriter, so mandated data collection. This is data from MUSC and UVA, where over 1,000 patients were included in almost a year's worth of procedures. And we found that in our hands, in 2 tertiary care endoscopy units, the rate of complete extraction of common bile duct stones less than 1 centimeter was about 95%. So in our setting, this was in keeping with the established parameters in the recommendations. So with respect to your average biliary stone, these are the tools of the trade. On the left, you can see the extraction balloons that are commercial, some of which are commercially, all of these are commercially available, and some are represented here. Similarly, on the right, the baskets that you can find. And really, for the majority of small stones, either of these techniques with a sphincterotomy will be successful. So with respect to how to remove these stones, standard case would be an adequate sphincterotomy. Size it to the size of the stone. You then use an extraction balloon. Typically, that's what I use, or a basket. Size it to the size of the stone or the duct. With the scope in the short position, fix your catheter in the accessory channel and deflect your tip away. I usually tell my fellows to big wheel away. This uses the lever arm of the scope to kind of provide traction as well as some fine ability to transmit force. For larger stones, you can push the scope in and torque. However, this more aggressive move may result in guide wire loss. And remember, for large stones, remove them one at a time. So this is an algorithm from the ESGE's 2019 guideline. And I'll focus on the right, where we're talking about difficult stones, where they define these as stones greater than 1.5 centimeter, multiple stones, narrow distal common bile duct, or an angulated distal common bile duct. And in these cases, a limited sphincterotomy with endopapillary large balloon dilation in patients who have not had a sphincterotomy, or if you've had a sphincterotomy, endopapillary large balloon dilation can be performed. For those patients who have failed stone extraction, then you can up the ante to mechanical lithotripsy or cholangioscopy-assisted lithotripsy or external shockwave lithotripsy. In situations that fail or where some of these advanced techniques are not available, please, of course, insert a stent and refer the patient to a tertiary center, or in some cases, consider surgery. So with respect to some of these techniques, first talking about sphincterotomy and large papillary balloon dilation. This is an example of a rather unremarkable major papilla. You can see here a couple of stones bigger than the width of the duodenoscope, so probably on the order of 12 millimeters. We cut a adequate sphincterotomy here really to the duodenal wall, and a 13.5 millimeter dilating balloon is used, and the stones are removed sequentially. Of course, you don't have to remove stones for documentation. In this case, I did, and you can just see the representative findings. So the ASGE in their 2019 guideline did discuss some techniques, and they said that in patients with large colorectal lithiasis, it's suggested to perform large balloon dilation after sphincterotomy rather than sphincterotomy alone. This was a conditional strength recommendation with moderate quality of evidence. This is another case of a 71-year-old patient who had two large 12 millimeter stones seen on CT. There were cholestatic liver-associated enzymes, and he presents for ERCP. After access, we cut a adequate sphincterotomy here to the lateral duodenal fold, and you can see the two large stones here. The duct is dilated to about 13.5 millimeters, and then in sequence, we remove the bile duct stones, and you can see here, we're sweeping with the balloon. This is a little bit of a larger stone, so the scope is being pushed in and torqued to try to get it out. Stone comes out pretty readily, as you can see here on the representative white light images. And while you don't always have to do this next step, we do have ability to do 3D cholangiography using our multi-purpose fluoroscopy table. And in this case, we show that no other stones are made. So best practice advice for endopapillary balloon dilation, and particularly for large balloon dilation: perform at least a limited biliary sphincterotomy. Do not dilate to a size larger than the proximal duct. In one study from friends in Taiwan, David Liao and colleagues found that in a randomized fashion, when patients were randomized to 10 millimeter balloon dilation, irrespective of their duct size, it could be smaller, there were 0 perforations. Generally, up to 12 millimeters is safe in most ducts, but perforation risk really picks up after 13 to 14 millimeters. Patients who have a long distal stricture, 1 centimeter or longer, it's best to consider other modalities and perhaps avoid large papillary balloon dilation. Now, after most therapeutic ERCP maneuvers, I think it's reasonable to perform what some call a negative perforation study. Really either sweep through with contrast or just watch contrast drain from the duct, and note it in your note. This is an important step to make sure you haven't injured the duct and caused extravasation. It can also be important medically. So this was a study, a multi-center study of large papillary balloon dilation in patients following biliary sphincterotomy. Median diameter was 13 millimeters, and this technique was successful in 95% of procedures. However, mechanical lithotripsy was required in more than 27%. So this is an example where the large papillary balloon dilation by itself is not sufficient and adjunctive steps are required. So moving on to mechanical lithotripsy, on the left is a commercially available lithotripter that accepts wires from a cut basket sheath. In the middle are examples of baskets that can be converted to lithotripsy. These baskets can be passed through the duodenoscope. And on the right is another emergency lithotripter. So with respect to how this works, there's a flexible metal sheath and a cranking device. The metal sheath is pushed onto the basket, and when it's cranked, provides crushing force. This is invaluable when a stone or basket are trapped. So in general, in patients where a basket requires more help, make sure that you, after grabbing the stone, you cut the basket at the handle, exposing the wires, if that's the type of lithotripter you use. Remove the sheath and the scope simultaneously. Then you advance the metal sheath over the cut wires. And depending on the type of lithotripter you're using, if there is a plastic sheath, please make sure you retract that so you have good metal to metal contact with the basket. And then you crush the basket against the sheath slowly so that the stone doesn't fall out and so that you could get good crushing force. This is an example of the adverse events that can occur with the cutting, with the wire cutting the incisura and lesser curve. So with respect to large balloon dilation versus mechanical lithotripsy, this was a prospective randomized study, and it actually found no statistically significant difference in terms of efficacy of removal of stones. But you'll notice here that in the large balloon dilation arm, there were fewer adverse events compared to the mechanical lithotripsy arm. So what do you do if an impacted basket occurs and then the emergency lithotripter fails? Well, options include shattering or dislodging the stone and freeing the basket using a large balloon, laser or electrohydraulic lithotripsy, or even emergency extracorporeal lithotripsy. Surgical intervention is always a possibility. In this case, you have to make sure the patient is intubated and they go to the OR with the baskets hanging at the mouth with or without the scope. This is an example of a rather unremarkable papilla. Patient had a large stone. There's a periampullary diverticulum. We cut a adequate sphincterotomy. And here you can see that there's a relatively long distal segment of the bile duct, narrow compared to the proximal segment, and a large stone. I thought this was an ideal case for mechanical lithotripsy, and we used an over-the-wire device through the scope. The wire is removed, and then here we're trying to destroy the stone. However, in this case, I thought it'd go great, but as we crank, the wires break. And the wires actually are not breaking inside the duct, and the olive stays put. The stone is trapped, but the wires break in the handle. And so in this case, and I've done this before, I actually put down a dilating balloon and thought that I could dilate and remove everything or pop the stone out. But in this case, the dilating balloon actually shredded, and I had to go down with a gastroscope to remove pieces of it. So that wasn't going to work. Then, kind of in traditional fashion, we removed the duodenoscope. We put the emergency lithotripter on it, and this you can see us passing the metal sheath through the stomach into the duodenum. And actually on 2 separate attempts in doing so, the wires broke again at the mouth. So this is the first attempt. And this is the second one where we're going through. You can see us getting up in the duct, and as we crank, the wires break. So at this point, the wires are barely visible at the bite block. We put a Kelly clamp on the wires, and then, we're left to think what next. Here you can see the wires in the stomach. So in this case, I did try single operator cholangioscopy, but I couldn't get a good angle to target the stone with all this stuff in there, and I couldn't fragment it in that way. So we were able to actually put a wire into the cystic duct, and then we used a very large balloon, 15 to 18 millimeters. At this point, either the patient was going to the OR there was a perforation, I was willing to accept that. And in this case, we're able to destroy the basket, shoot the stone out into the cystic duct, and then we could remove everything, placing a plastic stent. In this patient, they actually went to the OR for cholecystectomy, and the surgeon was able to incise the cystic duct and remove the stone. So with respect to the ASGE guideline, it does make room for using intraductal or conventional therapy with papillary balloon dilation for these large stones. ESGE also recommends mechanical lithotripsy for difficult stones when sphincterotomy and endoscopic papillary large balloon dilation has failed or is not appropriate. Things that can be used to predict failure includes large stone size, 30 millimeters or greater, or a stone to duct diameter ratio of greater than 1. We talked about some of the things that can happen, but the overall rate of adverse events about 3.5%. So moving on to intraductal lithotripsy, there are really two commercially available modalities here. This is EHL. This is a small footprint system that can sit on your endocart, and it uses electric high voltage spark between electrodes located with the fiber to deliver short pulses that create expansion and a spherical shock wave through the liquid to fragment the stone. It's important to use saline and not water. The probe should be positioned about 1 to 2 millimeters from the stone, and it's important to start with low power and work your way up to extend the probe life so you hopefully don't have to use multiple probes. The other alternative, and this is actually what we use, is a Holmium-YAG laser lithotripsy system. Here, a high-powered density laser focuses on the surface of the stone, creating a plasma bubble that oscillates and causes cavitation, fragmenting the stone. Generally, this is done when in a liquid medium, such as water. However, this is just a benchtop demonstration of the power of the laser, what it can do very quickly to a piece of cardboard. So this is an example of a patient with very large bile duct stones. You can see they're at least 2+ times the width of the therapeutic duodenoscope. We've cleared the stones in the distal duct, and now we're using single operator cholangioscopy with laser lithotripsy to target the stones. My typical technique is after putting water in the system, I touch the stone and I back up a tiny bit, and then I fire the laser, as you can see here. Just going to fast forward through this for the sake of time, but this is one of the larger stones that we're fragmenting using the laser. And sequentially, you can actually pulverize and fragment these stones to a size that can be removed pretty readily. In this case, it did take more than one procedure, really, just because of the large number of stones, but we were able to, using this technique, clear the ductal system, and the patient did well. So this is just one study, but it does compare in a systematic fashion almost 2,000 patients who underwent EHL, laser, or external shockwave for difficult to clear bile duct stones. And in this particular study, which actually did not include any randomized data, laser lithotripsy had a higher complete ductal clearance rate, higher stone fragmentation rate, as well as fewer adverse events. But really, I think the ASGE and ESG guidelines support any one of these modalities in a comparative way. So lastly, covered metal stenting. It's interesting, actually, in my perusal of the literature, there's really very few published studies using this technique, which I've used for some time. It's important to remember that use of fully covered metal stents for this indication in the US is off-label. But in this retrospective study, 44 patients with difficult to clear stones had a fully covered metal stent placed after an incomplete ERCP. And on the follow-up ERCP, just done about 8 weeks afterwards, 82% had successful ductal clearance. However, it's important to remember that in this series, there was about 23% stent migration, and the stents used were those without anchoring fins. So moving on, lastly, to adjunctive therapies, the ESGE does suggest against use of ursodiol or other choleretic agents, either to treat bile duct stones or to prevent the recurrence of stones after endoscopic clearance. This is a weak recommendation. ESG also suggests against considering external shockwave lithotripsy when ESG suggests considering external shockwave lithotripsy when conventional techniques have failed at ductal clearance or other advanced techniques may not be available. Lastly, ESG suggests that in patients undergoing lap chole, that transcystic or transductal surgical exploration of the bile duct can be safe and effective when expertise exists. So I'm not going to go through the take-home points because I'm out of time, but overall, ERCP is successful at removing the majority of simple and complex stones. Advanced endobiliary techniques often are adjunctive and can be used in tandem and in sequence. Overall guidelines are helpful, but remember, you should really know what you're doing and really focus on doing what you know. These are the two resources that I've been quoting throughout my talk, and I'll direct you to them. Thank you for your time and attention.